Well, welcome back, everyone. Again, my name is Kevin L. Hayek. I'm an assistant professor of surgery here at Case Western Reserve, University School of Medicine, Cleveland Clinic, Lerner College of Medicine. I'm also one of the general surgeons in the section of hepatobiliary and surgical endoscopy here in Cleveland Clinic. Today, we're going to talk about gastrointestinal bleeding, mesenteric ischemia, and the acute abdomen. Very, very large topics here. Can spend a lot of time on each of them, try to give again, high-level overview with some updates from recent literature and controversies within the field of general surgery. I have no disclosures. So just as an outline, we'll go through each of these topics in detail, first starting with gastrointestinal bleeding. We'll then move to mesenteric ischemia. We'll discuss acute abdomen, and then I'll end with two cases that highlight these diseases. Gastrointestinal bleeding is a very common presentation for patients, about 300,000 hospital admissions annually, and about 20,000 deaths a year in the United States. A patient who presents with GI bleeding has about a 3.5 to 10% mortality. And in terms of economics, each of these admissions is roughly $17,000 US per patient. So not only a clinical disease, but also one that affects economics within healthcare. Clearly a hot topic as we talk more about managed care and how to pay for some of the diseases that we're presenting with as patients. In terms of the incidence, overall, the incidence is decreasing, and part of that is due to a better ability for primary care physicians to identify this earlier, potentially to get this treated using IV iron or oral iron supplementation, finding the main sources, getting those stopped. However, with the increased incidence of blood thinners and things that are increasing with heart disease and some of the other comorbidities, some of the major bleeding episodes are increasing significantly. So some of the novel anticoagulants for heart disease, for atrial fibrillation, and again, just the increasing age of our population has meant that as people get to a point where they're having bleeding, these are more severe. So while the overall incidence is decreasing, we are seeing the severity and the complexity of this increasing. Risk factors include advanced age. As we age, our lining within our intestinal tract tends to thin, become more sensitive to outside factors, to environmental factors. And again, as we start to have barrier disease from medications, from polypharmacy, we tend to see an increased risk. Cirrhosis with varices, variceal bleeding, another major cause of gastrointestinal bleeding. Helicobacter pylori infection causes gastritis, again, decreasing the barrier function of the lining of the stomach, and this leads to bleeding. NSAID use for musculoskeletal disease also will increase the gastritis risk and bleeding. And as I mentioned before, anticoagulation is another major risk factor. Malignancy, in particular, GI malignancies, stomach cancer, small bowel cancer, colon cancer, all of these can present as the source of the active GI bleeding. And so this has to be something that is considered quite carefully as a patient presents with bleeding. In terms of classifying these are looked at as variceal versus non-variceal, acute versus chronic, and then we start to talk about the location. Upper GI bleeding, which is anywhere from the esophagus down to the end of the duodenum. Lower GI bleeding is going to be colon, mainly colon and end of the distal small bowel. And then obscure is typically going to be found in the segments of the bowel that we're not able necessarily to reach via endoscopy. So the segments of small intestine, the mid-jejunum forward. Sometimes these are also from proximal sources or distal sources, but because these can't be seen endoscopically, it's usually within the small bowel. Upper GI bleeding makes up the lion's share of these cases. About 66% or 2/3 of cases are all coming from upper GI bleeding, the predominant source being peptic ulcer disease. The remaining is typically lower GI bleeding, and a very small fraction, probably less than 10% of all cases, would be classified as obscure GI bleeding. Variceal bleeding is, of course, in the setting of cirrhosis, the main causes of which are alcohol use, hepatitis C virus, and increasingly in the United States, non-alcoholic steatohepatitis or NASH is also one of the leading causes, and now becoming a more common reason for patients to develop cirrhosis. So this would be in the setting of severe morbid obesity, or even just from a typical American diet. For non-variceal bleeding, this is your upper versus lower, and these will present with melena, hematochezia, and hematemesis. In terms of the presentation of obscure GI bleeding, this is usually not massive bleeding. This is usually slow bleeding that can lead to fatigue over the course of many weeks and sometimes months, leading to a slight but slow drop in the hemoglobin, and these patients will then present with fatigue. Let's move on to diagnosis. History and physical exam for all patients is going to be the most important thing initially. We want to focus on the vital signs to make sure that these patients are not having a massive GI bleeding that's going to require immediate intervention. So vital signs is very important. From there, we move toward laboratory evaluation, CBC, complete blood count, complete metabolic panel, and especially for patients who are on blood thinners, coagulation factors, understanding of platelet count. These are all very invaluable sources of information as we move to making a diagnosis. From there, the real gold standard for diagnosing gastrointestinal bleeding, especially if it's considered to be presumably an upper GI source, would be a rapid upper endoscopy. So really shifted toward getting these patients into the endoscopy suite soon, so that we can identify the source and potentially treat it quite quickly. Colonoscopy, normally we wouldn't go straight to a colonoscopy unless there was an active bright red blood per rectum and something that we felt that was going to be coming from the colon. But again, these are patients that are typically presenting to the emergency department or in an more acute setting, and for that reason, they will not have a bowel prep, and so colonoscopy may not be as helpful. So the typical pathway is to start with an upper endoscopy, and then if that is negative, to proceed with an appropriate bowel prep, and as long as the patient is stable, to proceed with colonoscopy. Treatment is mainly going to be focused on first patient stabilization. We'll read about large bore IV IVs placed within the anacubital fossa bilaterally in a large vein with a large bore, and then starting these fluids. There's been a lot of debate on crystalloids versus colloids versus blood, and there's really been no additional benefits seen with colloids, and so our typical recommendation will be to start with crystalloids, 500 cc to 1 liter bolus, and to monitor the stabilization of the patient. At this point, I think it's very, very valuable to alert members of gastroenterology, interventional radiology, and surgery relatively simultaneously. And the reason for this is that there really are a lot of pathways and no true level 1 data to suggest that that there's a one-size-fits-all protocol. So getting the gastroenterology team involved, getting the interventional radiology team involved, and definitely alerting the general surgeon, I think is an appropriate thing, in particular if this patient's in the emergency room. There's been a push toward a restrictive strategy for blood transfusion, so avoiding use of blood immediately for the treatment of GI bleeding. The main reason for this is that a lot of these, if they can be found early, could potentially be managed with crystalloids, as mentioned earlier. and potentially if this could be stopped to start an iron infusion or oral iron to get this patient's hemoglobin back up. So now the recommendations are that if the patient's hemoglobin is 7 grams per deciliter versus 9, if it's under 7, it would be reasonable to proceed with a blood transfusion, but 7 to 9, if the patient has no cardiac disease and is otherwise relatively healthy, to go ahead and hold off on a blood transfusion. Another restrictive strategy is in the platelet count. If these are less than 50,000, it would be reasonable to add platelets. However, in the 50 to 100 range, again, it would be reasonable to hold off. A quick word about novel oral anticoagulants. This is your Xarelto and other agents, Rixtra. These are newer agents that are less well studied, and we don't quite understand as much in terms of reversal. And so these are important ones to keep an eye on, especially as we're working toward preserving our blood banks. But these are patients that, if we're not able to get good stability with crystalloids, would be reasonable to offer blood. There are 2 scoring systems in use for gastrointestinal bleeding. The Rockall score as well as the Glasgow-Blatchford score. The Rockall score has been around since 1996, includes the age, the presence or severity of hemodynamic compromise, the diagnosis, and whether or not there's been recent hemorrhage. For the Glasgow-Blatchford score, hemoglobin, blood urea, pulse, systolic blood pressure, and other markers are used. Here those are in table format. And so typically what we'll get is a score for each of these. The higher the score, the more severe the bleeding. And this will dictate a couple things. Number 1, prognosis for the patient, and number 2, the need for intervention and how quickly this is. You can see here for men and women, obviously there's different hemoglobin cutoffs in the Glasgow-Blatchford scoring, as well as the components associated with those. Moving on to treatment from an interventional standpoint, once the patient has been stabilized, in many cases now, patients again are presenting on blood thinners, and the typical scenario might be that they get admitted, their blood thinner gets stopped, they have some melena or hematemesis. As their blood thinner is stopped, the endoscopy is ordered, they maintain stability, and then by the time we get to perform an endoscopy, there may not be any active bleeding, and that's very common, and it's okay. But I think it is important to proceed with the endoscopy. It's a relatively safe procedure, and it will allow us to find out if there's any evidence of previous bleeding and something that could be stopped before patients restarted on their anticoagulation. So during the endoscopy, the tools that are available currently include injection with epinephrine, thermal energy such as coagulation, cautery, argon beam plasma coagulation, and mechanical methods such as endoscopic clips, topical agents we'll talk about. And the key here, especially from a standpoint of testing and being tested on these, is that the use of combination of 2 of these is going to be better than trying to do this with one source alone. So the choice is to proceed with the sclerotherapy needle with epinephrine injection versus a thermal cautery versus doing a mechanical and an injection. The answer would be that we should do an injection and mechanical. So my normal pathway, if I see something that's a mucosal bleeding, is to go ahead and do an injection. After you've done an injection, that'll lift the mucosa up, and then a clip or a cautery on top of this would be enough. From an interventional radiology standpoint, there are going to be a number of tools available, the most common of which are going to be embolic agents. So the radiologist will access the mesenteric vasculature via the arterial systems, the celiac artery for upper GI, the superior mesenteric artery for obscure lower GI bleeding. They will find the source with any blush and then use certain agents, coils, certain types of glues that can go ahead and coagulate those vessels. For someone who is maybe in an obscure GI bleeding pathway, the choice of using embolic agents prophylactically, for example, who has someone who's had a recurrent upper GI bleeding, a duodenal ulcer, this may be someone that we would do an empiric or prophylactic gastroduodenal artery embolization, and this can be embolized all the way through from the celiac trunk up to its tributaries through the superior mesenteric artery. Very uncommon for us to proceed with surgery for GI bleeding. Some of the only times that this might be necessary is that if you have a relatively good endoscopist or you're performing endoscopy and there's just no way to clear the blood from the stomach, despite using multiple methods and the patient's unstable, that may be someone that's going to need surgery. And typically what we would do in that case is make an anterior gastrotomy in a source of upper GI bleeding near the pylorus to make sure that if we do need to extend this into the duodenum, we can cut right through the duodenum, through the pylorus to identify a duodenal ulcer, over sewing this area. And then if we are performing a gastroduodenal opening, to proceed with a pyloroplasty. If it is in fact in an upper part of the stomach, this incision could be extended into the mid-body, and then that can be closed primarily or with a stapler. So just kind of going through a couple depictions. This here on the left show the typical source of variceal areas, first in the esophageal area, next in the periumbilical area, and finally in the rectal area down below. And so this might be a source of bleeding in someone with variceal bleeding. So these three areas can be identified. And then when we're going to perform an endoscopic management of this, we have band applicators that go onto the tip of the endoscope. We find those varices. These are graded, and if they're able to be kind of suctioned into that cap, those bands can be released. So this is a depiction of doing variceal banding for variceal bleeding. In terms of our standard peptic ulcer disease bleeding, there's 4 types. Type 1 including gastric, and type 2 being gastric and gastroduodenal, type 3 being prepyloric, and type 4 being up in the body, the stomach. Type 5 is another one that's been kind of introduced as NSAID-induced aspirin, ibuprofen, naproxen type products. And then on the screen right, Mallory-Weiss tears, which are mucosal tears. These are from retching. This may be in the history of someone with an alcoholism that is kind of retching, who develops these sort of longitudinal tears within the distal esophagus and proximal stomach. So for management of these, we will normally, again, as I mentioned earlier, use combination techniques, so an injection in multiple areas around where the active bleeding is, and then performing endoscopic clipping of the mucosa. This is normally going to be successful in greater than 90% of cases. For lower GI bleeding, the main source of these can be diverticulosis. That's depicted on the left side. This is outpouchings of the colon with vasculature, as you can see, that kind of pouches out with it. And this area can create bleeding. A lot of this is managed non-operatively, just again with management of patient's anticoagulation, potentially some blood. But if these are found endoscopically, can be managed. Below, we're seeing hemorrhoidal bleeding in a very similar manner as what was managed with the variceal bleeding. These can be retracted within a cap and then a band placed on the bottom of those, and that typically takes care of the hemorrhoidal bleeding. This is a depiction of colonic bleeding, and again using combination. Here, the use of endoscopic clips around the area. You can kind of still see that stream of blood, and then cautery right next to it. So these are two methods that are used and very effective to stop lower GI bleeding. Moving on to obscure GI bleeding, these are the most challenging of all GI bleeding sources. They make up, thankfully, less than 5% of all cases. And as I mentioned earlier, most of these are found within the small bowel. These are vascular malformations, small neoplasms, and varices. The common scenario clinically is a patient who has a congestive heart failure or another coronary artery disease that is on anticoagulation, can't come off of it because they've had a valve, and they continue to have GI bleeding that's leading to hospitalization. They've had an upper GI endoscopy, a lower GI endoscopy cannot be found, and these are patients that we have a tough time finding these and tough time treating them. So for diagnosis, they're still going to go through the standard diagnosis for upper and lower GI bleeding. They're going to get a lower GI endoscopy, and I think an important tip here is to make sure that ileal intubation is performed. The way that this can help is that if the colon is filled with blood and you intubate the terminal ileum and there's no blood there, we can pretty safely assume that this is a lower GI source. But if there's still blood in the terminal ileum, then this is going to clue us in that this is an obscure GI bleeding case, and we need to do more to identify it. Capsule endoscopy is a capsule with a camera on it that's either swallowed or placed within the duodenum, endoscopically released, and then takes pictures as it goes through. And this is then read, and based on the time and some of the mucosal folds, a good endoscopist can kind of identify at least a region of the small bowel where GI bleeding is occurring. And this can help us target either further angiograms, either with a CT angiogram or a mesenteric angiography. CT angiogram is going to be helpful for someone who has a larger GI bleed that, again, can't be found on endoscopy. And then we'll talk about tagged red blood cell scan, which is very sensitive for the amount of blood loss that's occurring, but not as sensitive for localization. And then reverse is true for mesenteric angiography, where we do need about 1 cc per minute bleeding into the lumen of the bowel, but it's also very sensitive for the location. So all of these are going to be your normal workup for someone with obscure GI bleeding. And once we get all these, hopefully we're able to target it and proceed with treatment. So from an endoscopic standpoint, there's balloon enteroscopy or push enteroscopy. Currently, we have a single balloon available. Double balloon technology has not been as available anymore for various reasons. But these are balloons that are kind of mounted on the back or are preloaded onto the scope design and allow us to sort of telescope the bowel around the scope to get as far as we can. And same with the double balloon, where one is held in place and sort of almost like an accordion, trying to bring that bowel onto the camera itself. A provocative angiography with embolization is probably one of the more nervous, anxiety-producing procedures. So this again is going to really require a very good communication between the surgeon and the interventional radiologist. This is where if we kind of have an idea where the bleeding is going to be, patients had a tagged red blood cell scan, we're presuming it's in the small intestine or distal small intestine. We would tell the interventional radiologist to go ahead and cannulate the superior mesenteric artery and to go ahead and inject TPA or heparin, and to see if they could induce GI bleeding while the patient is on the interventional table. At this point, they could then proceed with coil embolization, and if they're unsuccessful, this is a patient's going to need to come to the operating room. So again, the normal communication pathway would be that this patient is down in the interventional radiology suite with an OR available, and they're going to continue to try to localize this. If they can find it and stop it, great. No need for the OR. If they're not able to, this patient needs to go up to the operating room. And the final thing is intraoperative enteroscopy. This is where we perform either an open laparotomy, make a small incision within the small intestine and pass the scope through, versus now, which have been described as laparoscopic techniques, where we're able to place a trocar into the small intestine and then scope both ways until we find it. So there's some pictures from a patient who had obscure GI bleeding. Here's an open enteroscopy, so a midway point, and the small bowel is chosen as incision is placed into the lumen of the bowel. The scope is advanced, going both ways. Another description as to if this can't be, if the bleeding can still not be found, is to perform double barrel stomas and to see which side is bleeding, and then to come back and resect a sizable portion. The guiding principle here is to try to preserve as much bowel as possible to avoid any complications of large bowel resections. So the more we're able to target a discrete lesion, the better the patient's going to do long term. Here are some pictures from a laparoscopic equivalent. So in this case, what we do is place 2 transfascial sutures on the small intestine. We make a small enterotomy, and then using a 15 millimeter trocar, this is advanced into the lumen of the bowel, and then selectively we will pass an endoscope both proximally and distally. And in this case, we can kind of see the trocar here on the left side. The bowel is being intubated, and one of the reasons we use a 15 millimeter trocar is this really kind of holds that bowel in place and allows us to distend it. And here was a case where we were able to find a source of GI bleeding. This was managed endoscopically, and then we were able to actually retrieve this piece of bowel and performed primary resection of this small area. So this paper from Angrisani in obesity surgery in 2015 is highlighting some special considerations regarding gastrointestinal bleeding that I think are important to mention here. And that's that the trends in GI surgery worldwide are increasing, particularly in response to the obesity epidemic. And now we're starting to see on the order of 500,000 or more bariatric operations. And this is really a significant alteration in the GI anatomy. Roux-en-Y gastric bypass being done close to 200 to 250,000 times, and sleeve gastrectomy also on the rise, being performed actually more now, with other procedures being less often performed. So here are just some depictions of what that anatomy now is looking like. In particular, this is important for an endoscopist. Gastric bypass, we're going to have a very small pouch, then a roux limb up to that area, and this is kind of the endoscopic equivalents to A, B, and C. So the jejunocetostomy is roughly 150 centimeters away, and so the ability to really appropriately identify bleeding in these populations is a little more challenging. Sleeve gastrectomy is relatively normal anatomy, other than the loss of a significant portion of the stomach, and so the same typical endoscopic pathways can be performed. And the biliopancreatic diversion with duodenal switch is the least common of the 3, and again has some unique anatomy associated with it. There are some newer technologies that are valuable to talk about as well. On the top left here is an over-the-scope clip. And for more challenging bleeding that may not be well managed with the combination methods that we talked about, using these come in 10 millimeter and 15 millimeter sizes. It has sort of a bear claw configuration, and when we can kind of bunch that tissue up, sometimes helpful in a case of severe and uncontrolled GI bleeding. Going just clockwise to the right is this is an endosuturing device that can be used as well. Again, this is a lot more technically involved. You need a therapeutic scope and dual channel within the endoscope. And so this would be, again, reserved for those very, very challenging areas that can't be managed with the typical means. Hemospray is now an FDA-approved therapy that's used as a topical application, again, for maybe an area that has diffuse bleeding where clips and injection aren't going to be as helpful. And finally, the use of endoscopic ultrasound to identify varices and to inject these directly. These are now all being commonly used. So in summary, upper GI bleeding is the most common, followed by lower GI bleeding, and then followed by obscure. Multidisciplinary approach, really involving gastroenterology, interventional radiology, and surgery, is very valuable. And the therapy is typically driven by the location and the severity. So moving on to mesenteric ischemia, the other side of the coin. Now we go from bleeding to clotting. This is much less common, about 1 in 1,000 hospital admissions. However, the mortality is very high, about roughly 50% when we look at all cases of mesenteric ischemia. And this is more common in females. The risk factors include, very similar to GI bleeding, advanced age, smoking, hypertension, diabetes, cardiovascular disease, and other peripheral vascular disease. So this is really a vascular disease. Usually this is going to be caused by someone's underlying comorbidities, although there are scenarios where this can happen spontaneously in a relatively healthy patient. When we classify these, look at these in terms of being acute versus chronic, occlusive versus non-occlusive, and arterial versus venous. So just a depiction of the visceral vasculature. Here we have kind of an identification of the major artery and vein, which is called the superior mesenteric artery and the superior mesenteric vein. The celiac artery is above it. So we look at the vasculature being from 3 main trunks: the celiac artery, the superior mesenteric artery, and the inferior mesenteric artery. But truly the vast majority of the small intestine and colon are fed by the superior mesenteric artery and superior mesenteric vein. These run relatively parallel to one another under the neck of the pancreas, and will be the main target for what we're going to talk about today in terms of mesenteric ischemia. So going through each of these, for acute arterial occlusive disease, this is the most common cause of mesenteric ischemia, about 70% of all cases. Superior mesenteric artery thrombosis, which is de novo development of a clot within the superior mesenteric artery. That's a very common cause. However, thromboembolism, so this may be from atrial fibrillation with a clot flicking off and going distally, is another source. Mesenteric volvulus, either from prior surgery or extrinsic occlusion from a tumor or small bowel intussusception at the site of the superior mesenteric artery. Acute venous occlusive disease, so this is superior mesenteric vein thrombosis, about 5 to 15%. These are typically seen in patients with systemic coagulopathy, factor V Leiden disease, other coagulopathies. Any patient with an underlying malignancy is going to be at high risk. And now we're starting to see a fair number of post-surgical causes, and in particular, as mentioned before, bariatric surgery, and not necessarily Roux-en-Y gastric bypass. Even patients with sleeve gastrectomy, for some reason, we're starting to see an increased risk even after the bariatric operation, months and years later, where patients are developing acute venous thrombosis. Portal venous stasis and cirrhosis is another cause, although there's a little bit of a different pathway for those patients. Acute non-occlusive mesenteric ischemia, or NOMI, happens in about 20% of patients. And this is really from a low flow state, hypotension, hypovolemia, low cardiac output, or patient that is septic or has hypovolemic shock or septic shock who's on vasoconstriction from their inotropes. This is causing basically a clamping down of those mesenteric vessels. And then finally, chronic mesenteric ischemia, which is about 5 to 10% of all cases. This is typically found in patients with pre-existing arterial disease and other systemic diseases, Takayasu arteritis, lupus, Berger's disease, patients with aortic dissection, and a group of patients with cocaine use. It can also present with chronic mesenteric ischemia. In terms of diagnosis, we look again at the risk factors associated with the disease, any associated conditions. And then on the physical exam, we're going to normally see a patient who's not as tender, but has a significant amount of pain out of proportion. This is the the normal catchphrase associated with mesenteric ischemia. We may or may not hear an epigastric bruit, same with tenderness and acute abdomen we'll get to later, but if this has progressed to be a severe cause, then an acute abdomen is possible. For labs, we want to look at the fluids and electrolytes for imbalances, lactic acidosis, as well as nutritional parameters such as albumin, transferrin, and C-reactive protein. The gold standard imaging for this is going to be a very good mesenteric duplex ultrasound. This isn't always available, particularly in the emergency room. These are normally performed in a vascular lab. And for that reason, a CT angiogram with 2 phases to make sure that we're evaluating for venous disease is going to be a very good test to do. MR angiogram, again, is going to be better for patient with chronic disease, since these exams can take up to 45 minutes to an hour. So for someone you want to find the answer out quickly for, an MR angiogram is not the right choice. Upper and lower endoscopies are going to be helpful to evaluate the bowel integrity. However, this is small intestine, again, for the same reason for obscure GI bleeding, we may not be able to reach that. So this would be more helpful in a case of colonic ischemia. And then catheter angiogram is going to be helpful both from a diagnostic standpoint and, as we'll talk about later, potentially from a therapeutic standpoint. Based on the fluid and electrolyte imbalances, these should be corrected immediately. For patients who have mesenteric venous ischemia and a coagulation, is going to be helpful. Vasodilators, and there may or may not be a role for antibiotics if there's a concern for translocation. So the way this pathway occurs is that these patients develop first mucosal ischemia, as is the most sensitive area where the bowel is being perfused. This then progresses into transmural ischemia. And once there is sort of a correction of the fluids and electrolytes, the sort of second hit that can occur is something called reperfusion injury, where if they're starting to get reperfusion to that area, there can be a sort of a cascade from the inflammatory mediators that are released that leads to further ischemia. So it becomes somewhat of a vicious cycle. So kind of close identification of these patients and close follow-up is very, very valuable. For acute arterial occlusive disease, the most common, there has been a shift toward endovascular intervention. However, the standard, what we'll read about in most textbooks, is a thrombectomy, so superior mesenteric artery thrombectomy. At the same time, having some level of bowel assessment, in particular, depending on the severity and the longevity of the disease. So here we have a depiction of the aorta with celiac artery, superior mesenteric artery. The middle picture shows a superior mesenteric artery thrombosis or embolism. And then the standard pathway for embolectomy in an open fashion is to get proximal control of the superior mesenteric artery to make a arterial, longitudinal arterial opening, a thrombectomy, and then this is repaired either with a patch or longitudinally. For acute venous occlusive disease, these patients should be placed on systemic heparin. If there is no evidence of bowel infarction or necrosis, it's usually safe to proceed with heparin alone. It's very rare that we would need to proceed with a transhepatic percutaneous thrombectomy. However, thrombolysis may have a role in a patient with really, really significant disease. Really, I think is another important concept is bowel assessment in severe cases, which we'll sometimes see with small bowel pneumatosis. For non-occlusive mesenteric ischemia, there's no obvious targeted lesion. It's just the entire system is clamping down. The underlying cause is going to be the target. We need to really fix this. So this is a cardiac disease that should be managed. We should minimize vasoconstrictors. We can use catheter-directed vasodilators and open surgical evaluation of bowel. However, if this does proceed to need for open surgical evaluation of bowel, this is super high mortality rate. And I think a frank discussion with the family should be had, because this, given that it's not a discrete lesion that can be treated, the vast majority of the time, if there is bowel ischemia, it's the entire small intestine and sometimes the entire colon. So obviously, unless these patients are candidates for small bowel transplant later, you're really set up for a bad outcome for these patients. So things to consider: chronic mesenteric ischemia, endovascular stenting has become a really good approach for patients where this can be diagnosed early, more commonly seen for superior mesenteric artery versus celiac. And the stent occlusion rates are also much lower for SMA versus the celiac artery, mainly due to the length of the SMA and the angle in which it comes out is more favorable. Celiac artery stenting tends to have a higher rate of stent thrombosis. Open repair and open bypass is also another option for these patients. So this would be an open thrombectomy of the aorta on the left, a graft from the aorta to this superior mesenteric artery, and then in some cases where there's both chronic disease within the celiac trunk and the superior mesenteric artery, jump grafts to both of those. Follow-up for these patients should include management of underlying conditions, aspirin, clopidogrel, or Plavix for 1 to 3 months. This is specific for endovascular patients. Oral anticoagulation is debatable, and then a follow-up duplex ultrasonography to evaluate for either graft patency or restenosis. In summary, mesenteric ischemia is a very rare cause of abdominal pain. Having a high index of suspicion is very important. And these patients, despite the low incidence, have a high mortality and morbidity. And the value of vascular and general surgery collaboration it can't be stressed enough here. Moving on to the final topic, which is acute abdomen. Again, could spend a weekend talking about acute abdomen, so I'll sort of hit the high yield sources of this. This is sudden, non-traumatic, severe abdominal pain, less than 24 hours in duration, and the typical presentation is to urgent care emergency room, and prompt diagnosis is vital. Makes up about 7 to 10% of all emergency room visits, and actually the most common cause is medical. And so this is really going to highlight the need to make a surgical diagnosis if in fact it is, but most of the time these are medical causes. History and physical exam, laboratory testing and imaging is all we'll usually need for acute abdomen. The pain should be described in terms of timing, location, based on the quadrant. It really can kind of target what organ may be affected or whether or not this is diffuse. So is this a focal tenderness or focal pain, or is this a diffuse issue? The character, whether or not this is radiating. For example, something radiating to the right shoulder could be either hepatobiliary in origin, as well as exacerbating factors. Another thing to consider here is sometimes acute abdomen is a presentation for something that is actually not coming from the abdomen. For example, a atypical myocardial infarction can present with epigastric pain. So we really have to be very broad in our workup of these patients. Associated symptoms such as nausea and vomiting, bowel function, and menstruation. And the main reason for this is that sometimes these patients are in fact having an ectopic pregnancy instead of, again, a GI source. So making sure that we understand the menstruation pathway and whether or not they are in fact potentially pregnant. Physical exam, looking at their overall appearance. This is something that as we train residents, you pretty much can tell them, how's this patient look? And most patients with an acute abdomen who require surgery, you don't need to do too much workup. They look pretty ill, and we can pretty much make the decision that they're going to need something potentially surgical quite soon. Vital signs, again, very important. Abdominal exam, looking at inspection, palpation, percussion, and the focus on rectal and pelvic exam, again, to rule out any sort of ischemia from a rectal standpoint, making sure there's no occult blood or mucosal sloughing. And from a pelvic exam, this is to be helpful for evaluation and ruling out of an ectopic pregnancy. Laboratory studies, pretty broad panel of blood count with differential liver function panel, amylase lipase to rule out pancreatitis, urinalysis to rule out any sort of renal cause, pregnancy test, and arterial blood gas with lactate, and this will be helpful for someone with ischemia. From an imaging standpoint, the first set should be just basic plain films with an upright and decubitus. This will help to identify any pneumoperitoneum. An ultrasound is useful, in particular with someone such as children or even with a patient that may be pregnant. CT scan is going to be the gold standard with oral IV and in plus or minus rectal contrast, depending on what the presumed diagnosis is. A quick word about diagnostic laparoscopy. This is a very helpful additional test and can make the diagnosis in 90 to 98% of cases. It's particularly valuable in the morbid obese patient who potentially can't undergo a CT scan or where there's a questionable finding. It has largely replaced the previously described diagnostic peritoneal lavage technique, as this is a much more controlled way to enter the abdomen and a way for us to get anything we need in terms of samples, washing, and really to guide our next step. This also, in correct hands, can help us either proceed with the definitive therapy laparoscopically or proceed with an open surgical intervention. And this is a great tool to use in a patient that may have this non-occlusive mesenteric ischemia, where you're just trying to help the family make the decision to withdraw care, and you're just identifying global ischemia and not proceeding with a morbid laparotomy. So I think it's very important to have this in a surgeon's toolbox as a diagnostic test when the others have been maybe equivocal. In terms of treatment, I won't focus on the medical side of things, but obviously if it is in fact a medical cause, nephrolithiasis, pancreatitis, peptic ulcer disease, gastroparesis, gastroenteritis, hepatitis, these are all treated typically by a medical team, but I think it's important to play a part in that and to make sure that we have good collaboration with the emergency room to make sure that these are being treated. And sometimes there are more than one thing going on, so to make sure that the medical side is managed is going to be valuable. From a standpoint of surgical, I'll go through each of these and just some newer debates in terms of appendicitis, biliary colic or cholecystitis, perforated peptic ulcer, diverticulitis, bowel obstruction, and carcerated hernia. These are probably the most common causes of acute abdomen. So for appendicitis, the topic of great controversy lately has been whether or not patients should proceed straight to surgery or should have a trial of antibiotics alone. I would have to say that based on some of the literature, that more and more patients are asking whether or not antibiotics would be fine. And I've often seen many patients in the office who've been treated by antibiotics, either in a smaller hospital where they had lack of surgical coverage, and they're coming to discuss whether or not they need their appendix taken out. And what the brief summary of all the literature suggests that it's relatively safe to proceed with antibiotics alone in uncomplicated appendicitis without peritonitis. However, I think it's important to note there's about a 25 to 30% rate of either recurrent appendicitis or the ultimate need for an appendectomy for chronic symptoms in patients who have had antibiotics alone. However, I think in certain scenarios, if a patient is very ill and they're potentially on chemotherapy and a surgery might set them back, antibiotics alone is reasonable, and that should be something to consider from a surgical standpoint. For acute cholecystitis, the main questions are going to be the fitness of the patient. These are a lot of these patients are going to be older in age and may have a lot of the medical comorbidities beyond anticoagulation. Another topic of great debate is timing of surgery. Should the patients be admitted and have surgery within the first 48 to 72 hours, or should they cool off with antibiotics and come back? The next topic of debate is cholecystectomy versus percutaneous drainage. And And again, for someone who's relatively ill, percutaneous drainage is a great temporizing measure. We don't really know the long-term fate of a lot of these tubes. However, it is safe to assume that if they can be managed percutaneously and they are able to be followed later and they have a patent cystic duct, there's about a 70% chance that they will not need surgery. So again, similar to the appendicitis cohort, where about 30% of patients may develop recurrent cholecystitis requiring surgery. Something else that's come through the pipeline is endoscopic drainage, and this is going to be for a patient that potentially is just too sick to undergo any sort of thought of surgery. And what's being done in this regard is an endoscopic ultrasound via either the antrum or the duodenum, and placing a stent from the bowel to the infected gallbladder and allow this to drain internally. And this is a great option for someone who is not a great candidate for surgery. Perforated peptic ulcer. The main debates here are laparoscopic versus open. There's been good data to support performing a laparoscopic management of this type of repair, closure with omental patch or omental patch alone. And then my typical practice in this regard, if the patient is very sick, is proceed with a gastrostomy tube for drainage and a jejunostomy tube for feeding, as well as wide drainage of this area. This will allow you to continue the patient on enteral feeds to drain proximally and to allow this fistula to potentially close. For diverticulitis, very similar to appendicitis, antibiotics versus surgery, drainage, whether or not to proceed with laparoscopic lavage or percutaneous drainage. And then in terms of the operative approach, minimally invasive versus open, and then performing a stoma versus primary repair or diversion. For bowel obstruction, nasogastric drainage before anything is going to be the standard first line therapy. A small bowel follow through can sometimes help guide timing of whether or not this is going to require surgery or is going to be managed non-operatively. The vast majority of patients with bowel obstruction can be managed non-operatively, but once we start getting into a recurrent scenario, there should be a role for potentially investigating. Again, a lot of data to support laparoscopy as a source and as a approach in a stable patient versus a laparotomy with potential decreased postoperative morbidity. There's an ongoing randomized trial by Salinin and colleagues to see if this is actually going to result in earlier return of function and earlier bowel recovery. So we await the results of this trial. For incarcerated hernia, an attempted reduction after anesthesia is a very appropriate source. This patient may not have the ability to have a reduction done in the emergency room or an initial evaluation. The approach being a minimally invasive versus open. If it is going to be done minimally invasively, the question of putting the laparoscope into the bowel, into the abdomen to assess the bowel for ischemia versus necrosis, because if we're performing this open, we're typically getting a very good look at the bowel to decide whether or not a resection needs to happen. And then finally, mesh choice versus primary tissue repair. Knowing that a primary tissue repair, in particular in a high-risk patient, is about 50% failure rate, when is it safe to proceed with a mesh placement and what type of mesh to be used? There are just hundreds of mesh options these days in terms of permanent versus absorbable versus xenografts or allografts. I think it's important to kind of understand this. Again, another topic for another day, given that there's just so many possibilities to answer here. But I think the consensus should be that it would be safe to proceed with laparoscopy. It would be safe to place a mesh, but we obviously got to consider things like intraoperative contamination when doing this. So in summary, for the acute abdomen, a prompt diagnosis is essential. There's multiple medical and surgical etiologies. The CT scan is going to be the fastest and most sensitive test. But there is a role for diagnostic laparoscopy and minimally invasive surgery. And this is like many diseases that are complex in nature, best managed in a multidisciplinary fashion. So I'm going to finish with a couple interesting cases from here that the patients that I was able to treat over the last several years. This first patient is a 53-year-old female who had a laparoscopic gastric bypass 4 years prior to her presentation. And she actually presented with melena and acute blood loss anemia requiring blood transfusions. 6 months prior to her presentation, she actually underwent a laparoscopic mesenteric defect volvulus repair with suturing of the mesenteric defect. And this is a common cause of abdominal pain in patients after weight loss following a laparoscopic gastric bypass. She was getting a unit of blood every 3 to 4 days and an extensive workup, including an upper endoscopy, colonoscopy, capsule endoscopy. All these were done outside, and there was no kind of targeted area that was actively bleeding for them to manage. So this patient was diagnosed with obscure GI bleeding in a post-surgical case and was transferred to us for further workup. So we started with a CT scan, which was done as a CT angiogram with 2 phases, and this is the venous phase. And what these arrows denote is a complete occlusion of the superior mesenteric vein proximal to the splenic vein. And so we see that there's absolutely no flow from the superior mesenteric vein below the confluence of this splenic vein. So what this blue arrow denotes are massive venous collaterals within the mesentery of the small intestine. And so the patient proceeded with an upper endoscopy, and the picture on the left shows the gastrojejunal anastomosis. And as you can very clearly see, there are massive varices just along the edge, as well as within the small intestine. And the second picture shows the venous, the jejunojejunectomy, with the left side showing relatively normal bowel, and the right side showing a significant amount of varices as well. So this patient underwent ultimately a mesenteric angiography, and the section on the left, picture on the left, shows the superior mesenteric artery, and the picture on the right shows the venous drainage. And up by the catheter tip, so the white arrow shows that superior mesenteric artery, the blue arrow shows the occlusion area of the superior mesenteric vein, with the second blue arrow showing those huge collaterals that I mentioned. And there is recannulation of the portal vein approximately, but this was found to be via the coronary vein, or the left gastric vein. So a very kind of odd drainage pattern back to the portal vein. So despite many, this patient we had a multidisciplinary meeting and ultimately decided there was anything that any endoscopic or interventional radiology could do. And so we took this patient to surgery, performed a laparotomy, a resection of the jejunojejunectomy, the roux limb, and the gastrojejunectomy, and effectively restored her normal anatomy, a gastrogastrostomy and a jejunojejunectomy, presumably changing the high pressure system from the chronic roux limb varices. These varices were all within the roux limb up to the gastrojejunectomy, and effectively she was decompressing into the small intestine. So pathology revealed multiple varices within the resected anastomosis, and the outcome was no further bleeding or transfusions. That being said, weight regain does happen in patients with reversal, and this was seen at her 8-month visit. For the second case, this was an 82-year-old gentleman with chronic constipation who developed acute abdominal pain at his rehab facility. This was 12 hours in duration. He had severe constipation and multiple medical comorbidities, was effectively pretty low function at a nursing home. So he presented to the emergency room and was found to have this acute abdominal series with severe dilated bowel. And on CT scan, it was found to have evidence of pneumoperitoneum, free air, as well as significant bowel dilation throughout the entire abdomen. This, again, you can kind of see the free air here, as well as significant bowel dilation. So this patient was a clear case of acute abdomen, tenderness on exam despite his inability to really communicate well with us, but image findings consistent with an acute abdominal process. So this patient goes straight to the operating room. There would be, in my opinion, little role to perform laparoscopy given his stability. He was on multiple pressors. So proceeding with a laparotomy, a colon resection, and in this case, a temporary abdominal closure. So this is what we encountered on entry, a very severely dilated and ischemic colon. This was resected in its entirety. Patient was left open. We returned for a second look and he had additional colonic necrosis as well as toxic megacolon. So proceeded with a colectomy and ileostomy. And here's a patient that, again, given his function preoperatively, I elected to place a gastrostomy tube for feeding access and abdominal closure at that point. His pathology showed severe ischemic damage, full thickness necrosis, additional colonic mucosa with ischemia, and his outcome was a prolonged ICU stay, tracheostomy, and ultimately a discharge to long-term acute care. So in conclusion, GI bleeding, mesenteric ischemia, acute abdomen, these are common general surgery diseases. GI bleeding probably more so than mesenteric ischemia, but acute abdomen also going to be very common. Prompt diagnosis is vital. There is no one-size-fits-all approach and very little level 1 data to support one way versus another. And so I think for these cases, precision option based on team consensus provides the best care for patients. A lot of this will depend on your center's expertise and what everyone's able to do. But from a standpoint of getting people together to come up with good pathways is going to be the best way to get excellent care for these patients.